All right, let's jump right into this explainer. We're tailoring this specifically for your ASCP-BOC prep, which means we are moving at a rapid board review pace. Every single number we talk about today counts. We're conquering the myeloid journey, tracking the exact progression from a primitive blast all the way down to a mature cell. So grab your notes because we're not leaving absolutely anything out.
But before we hit the myeloid branch, let's do a super quick 20-second recap to anchor our last session. Remember your blood basics. We've got 4 to 6 liters total, and the pH is tightly controlled right at 7.35 to 7.45. On the smear, that 0.05 molar sodium phosphate buffer at pH 6.4 is absolutely critical for a perfect right gene sustain. We track the hierarchy from the pluripotent hematopoietic stem cell straight down to the committed myeloid progenitor. We rely on growth factors, like GM-CSF for broad myeloid production and specific interleukins, and of course, we just nailed that 5-day erythroid line driven by EPO.
Here is our agenda for today, mapping out the whole lineage journey. We're going to orient ourselves on the smear, strictly track neutrophil maturation and function, break down eosinophils and basophils, and then finish strong with monopoiesis and those massive megakaryocytes.
Okay, so the absolutely crucial point for orientation on a normal smear is to always, and I mean always, use the 7 to 8 micrometer mature biconcave red blood cell as your built-in microscopic ruler. Measuring against that standard RBC is what lets you accurately gauge the size of literally every single neutrophil, eosinophil, basophil, lymphocyte, and monocyte you're going to encounter on your exam. It's your baseline. Now, as we trace the production of neutrophils, eosinophils, and basophils, you have got to remember these universal maturation rules. Across the board, as these cells mature, the overall cell actually shrinks in size, and that nucleus to cytoplasm ratio, it decreases. The nuclear chromatin severely condenses, and those nucleoli completely disappear. Crucially, early primary granules are lost just as the secondary, specific granules start to appear. Plus, the cytoplasm transitions from a deep, RNA-rich blue to a nice, mature light pink.
All right, let's start our baby pigs may munch bacon slowly mnemonic right at the beginning with the myeloblast. Check out that massive 4:1 N to C ratio. This cell is big, 10 to 20 micrometers large. The nucleus has smooth chromatin with one or more prominent nucleoli, and there are absolutely no granules yet in that light blue cytoplasm. That means you can't even identify the specific lineage at this point. It makes up less than 1% of normal bone marrow, and you should never, ever see this in normal peripheral blood.
Moving right along to the promyelocyte. Now what's really cool here is the appearance of the very first granules. These are your primary granules, and they are heavily loaded with myeloperoxidase, or MPO. The cell is around 20 micrometers, though it can vary a bit. The N to C ratio drops slightly to 3:1, nucleoli are still hanging around, and you'll often spot this distinct pale Hov zone right next to the nucleus. This stage makes up about 1 to 5% of the marrow, and, just like the blast, shouldn't normally be hanging out in peripheral blood.
Next up is the myelocyte, sizing in at 10 to 18 micrometers. This is actually a major milestone. It's the very first cell you can definitively identify by its lineage. For example, a neutrophilic myelocyte. Why? Because of the arrival of specific secondary granules containing alkaline phosphatase. The N to C ratio drops to 2:1 or even 1:1. The nucleus gets a bit oval and eccentric, the nucleoli fade away, and the cytoplasm takes on this pinkish hue. It accounts for 2 to 10% of the marrow and only ever shows up in peripheral blood during an infection, which triggers that classic left shift.
And here, we hit the no more mitosis phase. The metamyelocyte, which is typically a bit smaller than the myelocyte at 10 to 18 micrometers, has an N to C ratio of 1:1. It has lost its nucleoli entirely, meaning, it can no longer divide. The chromatin clumps up significantly, and the nucleus takes on this very classic indented kidney bean shape. Making up 5 to 15% of the marrow, it only joins the peripheral blood when your body is actively fighting off an infection.
So, the band stage. This one is characterized by a very distinct horseshoe-shaped nucleus with heavily clumped chromatin. The cytoplasm is totally packed with those small secondary alkaline phosphatase granules, though, a rare primary granule might still linger. Normally, bands represent just 2 to 6% of peripheral blood white cells, but this number spikes dramatically, shifting to the left during active infections.
Finally, the mature segmented neutrophil, or PMN. It comes in at 10 to 12 micrometers with a low 1/3 N to C ratio. It boasts 2 to 5 distinct nuclear lobes. This is a brilliant adaptation that literally allows it to squeeze right through endothelial linings to get into the tissues. The cytoplasm is light pink with neutral staining secondary granules. Make sure you memorize these ranges. They make up 50 to 70% of adult white blood cells, but small children naturally run lower, hovering right around 30 to 55%.
Let's see how all this structure builds their ultimate function, fighting infection through phagocytosis. It's a strict 3-step sequence. First, migration to the site. Second, opsonization, where the target gets marked. And third, ingestion, killing, and digestion. They pull this off using their granules, which are actually just lysosomes heavily packed with phosphatase, NADPH oxidase, and lactoferrin. They'll leave the blood after about 7 to 10 hours and then live out their days in the tissues for 2 to 5 days.
Now for your boards. You absolutely must strictly distinguish between these two terms. Neutrophilia is an increased relative percentage of neutrophils, classically signaling an active infection. Neutropenia, on the flip side, is a dangerous decreased absolute number. This can be caused by a severe bacterial infection that's actively depleting your neutrophil reserves, or viral infections, certain drugs, or even allo and autoantibodies destroying the cells. Pivoting away from neutrophils, let's talk about the eosinophil. It sits at about 13 micrometers and makes up 0 to 4% of normal blood. They typically have a bilobed nucleus, but honestly, you'll identify them by their striking, large, orange-red secondary granules. Crucially, these granules contain major basic protein that binds acid-aniline dyes, plus histamine, but 0 lysosomes. You'll see these numbers spike during type 1 hypersensitivities, think asthma, hay fever, allergies, as well as in parasitic infections, scarlet fever, post-splenectomy, and CML. Next is the elusive basophil. It's around 10 micrometers and represents a tiny 0 to 2% of peripheral blood. Its bilobe nucleus is usually completely obscured by these massive 0.2 to 1.0 micrometer dark purple granules. These water-soluble granules are loaded with heparin and histamine, and they have a strong affinity for blue or basic thiazine dyes. They increase in immediate hypersensitivity, CML, polycythemia vera, and with hematopoietic growth factor administration. Oh, and here's a highly testable fact for you. Both eosinophils and basophils exhibit diurnal variation. Their counts naturally go up at night and drop in the morning. Now, I want you to compare the circulating basophil you see in blood to the mast cell. The mast cell is a specific granulocyte of the connective tissue, not the peripheral blood. During allergic reactions, mast cells release immense amounts of strong chemicals, like histamine, directly into tissues and the bloodstream. This is what triggers severe itching, swelling, and dangerous throat-tightening muscle spasms or bronchospasms. Keep their tissue location completely distinct from the circulating basophil in your mind. All right, let's transition over to monopoiesis, tracking a line from monoblast to promonocyte to monocyte, and ultimately the macrophage. The monocyte is absolutely massive. At 14 to 20 micrometers, it's the largest white blood cell in peripheral blood, making up 2 to 9% of the total count. It has a highly variable shape with a 2 to 1 to 1 to 1 and a C ratio. You'll notice a lacy, kidney bean-shaped nucleus with fine strands, and abundant, dull, grayish-blue ground glass cytoplasm. That's from numerous fine reddish-purple granules. It uses rounded or blunt pseudopods to move around, and you might even spot digestive vacuoles holding phagocytized RBCs. Keep in mind, non-granular forms indicate a rapid turnover. Their main gig? Relentlessly processing antigens to pass infra to CD4 T helper cells, while producing and responding to interleukins and cytokines.
Once that monocyte leaves the blood and enters the tissue, it transforms into a macrophage. Acting as vital immune modulators, macrophages present antigens from ingested pathogens straight to helper T cells. They also act as the primary sanitation crew in the bone marrow, phagocytizing cellular debris and old red blood cells. A histiocyte? That's simply a slightly less phagocytic tissue variant of the macrophage. It has fewer lysosomal granules, but it's still a core part of that crucial reticuloendothelial system cleaning everything up.
Finally, let's examine megakaryocytopoiesis. This lineage progresses from megakaryoblast to promegakaryocyte to the mature megakaryocyte and finally into thrombocytes. The megakaryocyte is a total behemoth, measuring 30 to 100 micrometers. It is easily the largest hematopoietic cell in the marrow. It features a staggering N-to-C ratio ranging from 1 to 1 all the way up to 1 to 12. You won't find these in peripheral blood, but their marrow numbers will surge during acute bleeding or periods of high platelet demand.
The reason this cell is so massive is its endgame. A single colossal megakaryocyte will quite literally fragment its own cytoplasm to yield an incredible 2,000 to 4,000 individual platelets straight into circulation. It's like a biological factory.
Those resulting platelets or thrombocytes come in various shapes and measure a tiny 1 to 4 micrometers. They don't have a nucleus at all. They appear pale blue and are heavily packed with eosinophilic granules. For the BOC, you absolutely must memorize the normal peripheral blood count, 150,000 to 400,000 per microliter. On a perfect smear slide, that visually translates to about 7 to 15 platelets per oil immersion field. And remember, 70% are circulating while the other 30% are safely stored in the spleen.
As we wrap up this dense, high-yield review of the myeloid branch, I want you to ask yourself this highly testable board question. If you look at a smear and the morphology absolutely screams infection, maybe you see bilobed pince-nez nuclei looking like a severe left shift, but the total WBC count is completely normal, what's going on? Well, you're likely not looking at a true infection, but rather a benign inherited anomaly, like Pelger-Huet. So always check the total WBC count to confirm the story the slide is telling you. Keep reviewing these numbers, and I'll see you in the next explainer.